This talk is femoral acetabular impingement. Should we perform prophylactic surgery? The concept of the femoral acetabular impingement is an abutment conflict between the bone of the femur and that of the pelvis. It's a source of hip discomfort in patients with subtle abnormalities. There's two types of FAI, CAM type impingement and pincer type impingement. A combination is usually present. CAM FAI tends to occur in young active male patients. It's an abnormal radius of the femoral head impinging on the labrum. Pincer impingement tends to happen in middle-aged women. It's an acetabular abnormality leading to linear contact between the acetabular rim and the femoral head-neck junction. This is a video showing a femoral neck spur as well as an acetabular spur consistent with femoral acetabular impingement. These morphologic abnormalities lead to abnormal contact, which leads to tearing of the labrum and the cartilage. Further deterioration will lead to arthritis. Nonsurgical treatment leads to a high failure rate because it's a young active population with a mechanical problem. The goal here is to intervene early to prevent progression of arthritis. Symptoms greater than 6 months if articular cartilage is not severe leads to surgical intervention. The goals for surgery are to improve clearance of the hip motion and to alleviate the femoral abutment. This is an example of CAM resection. The femoral head has no offset. A burr is used to create offset between the femoral head and the femoral neck. Prophylactic surgery for FAI is controversial. The rationale is to correct the deformities before they lead to irreversible damage and arthritis. FAI to the left can eventually become arthritis, which you see on the right. Two questions. How often do we see FAI morphology in the asymptomatic population? And does FAI really lead to premature DJD of the hip? This study performed in radiology was a prospective study, shows a high incidence of CAM and pincer findings in asymptomatic patients. This is a population-based study that also shows a high incidence of CAM deformity in an asymptomatic population. A CT scan study again showed a high incidence of femoral acetabular impingement signs in the asymptomatic population. 10 to 74% of the asymptomatic population has FAI findings. Clearly not all of them need surgery prophylactically. Now does FAI in the asymptomatic hip lead to eventual degenerative arthritis? Gons felt that it did. Early surgical intervention is what he recommended so that these changes do not lead to premature arthritis. This data collected from Copenhagen for over 4,000 patients looked at the presence of acetabular and femoral deformity, and they found there was a high risk ratio for acetabular socket that was deep and CAM impingement leading to eventual arthritis. This study found that 65% of follow-up patients led to arthritis in 10 years with FAI. However, there are other studies that show that FAI hips do not lead to arthritis. This study looked at patients at a follow-up mean of 18.5 years and found that 82% of patients with FAI remained free of arthritis. So are there situations that support prophylactic surgery for FAI in the literature? This may be one in patients with bilateral FAI where the contralateral hip needed a total hip replacement. In those situations, early treatment of FAI may be necessary. Thank you very much.